typed in the emergency department. So this is a new role for me, so it's been kind of fun. We've had a little change in the program. Originally we were going to be doing pediatric census. Our speaker for that had a death in the family, so we asked him to just spend time with his family. So Stacy Hanover has graciously agreed to step in with a lecture on non-accidental trauma. So that'll be very just as good. So let's see. So we have 4 speakers total, 4 topics. We'll be starting with Erin Silva, who is our neurocritical care coordinator. And are you all set? Okay. Thank you.
Okay. I don't know if these are working. Let me know if you can't hear me. Like Fran said, I'm the now called Pediatric Neuroscience Center, probably going to change the name, but neurocritical care program coordinator. And like her, this is a relatively new role for me. I just started in October. And before that, I was in the ICU for about 11 years, both as a staff nurse and as the educator. So today we are going to talk about, or I'm going to talk about, pediatric post-concussion syndrome. So first I have my disclosure. I don't have any financial or commercial interest, just a topic that I find interesting. So our objectives for today are as follows. We're going to define concussion and post-concussion syndrome. We're going to identify common post-concussion syndrome predictors, and we're going to recognize our nursing implications for a patient who either has post-concussion syndrome or has predictors for it and just has a concussion. So we'll start kind of from the beginning with the Glasgow Coma Scale. I'm hoping all of you are familiar with this. It was first described in 1974 by Teasdale and Jennett, hopefully I'm saying that correctly. And it provides a score from 3 to 15. 3 is the lowest and the worst, and 15 is the best. It's composed of 3 different parameters: eye, verbal, and motor. And an important thing to note is when documenting GCS, you want to make sure that you actually document each individual component. You don't want to just put an 11 for GCS because it depends on where there is a deficit, whether it's eye, verbal, or motor, or all 3 of them. So for example, for 11, you would want to put E3, V3, and M5. This will give the person who is looking at the chart a better idea of what the patient looks like. So this is our Glasgow Coma Scale, and if you look at different tables that have it, the wording may be a little bit different. This is taken from the American College of Surgeons, which is used for the trauma quality improvement program, which we do here at Children's Hospital. So it may be a little different, but it's essentially, you'll get the same score. The problem is that GCS was originally developed for adult patients. Did not really have the pediatric patient in mind. And so they improved it or redid it and made it into a pediatric Glasgow Coma Scale. And you can see on here, for example, verbal is, I don't know if people can see this dot, it's my fancy pen. It says inconsolable moaning, inconsistently consolable and moaning for a pediatric patient. If you look back at the adult one, it says incomprehensible sounds and inappropriate words. And we all know that a patient who is 14 months old may have something that's incomprehensible or not appropriate, but that does not mean that they are have a deficit neurologically. So this is more appropriate for our pediatric patients. This is not in your handout. I added a few things this week, but this is what it looks like for our EPIC users. Right now, only available for PICU nurses, but in the future, available for acute care nurses as well. And GCS should be regularly documented. If you have Q1 hour vitals, or neurochecks, I'm sorry, you should be documenting GCS as well. Q2 hour neurochecks, documenting GCS as well. This is the greater than 2 years. And then this is the trauma flow sheet that our emergency room folks will use when they document GCS for our traumas. So, traumatic brain injury. A broad definition of traumatic brain injury is an injury caused by a bump, a blow, a jolt to the head, or a penetrating injury to the head that disrupts the normal function of the brain. So this can be anywhere or anything from a patient getting punched in the head, someone falling and hitting their head in the ground, a motor vehicle collision where they hit the dashboard, or even something like a gunshot wound to the head. And TBI is classified under as to severity as to mild, moderate, or severe. Mild is where the concussion falls in, and this is where GCS is also important because a mild TBI is a GCS of 13 or greater. They can have a mental status change or a loss of consciousness, but it has to be less than 30 minutes, and they may not have a loss of consciousness, but they will have some kind of mental status change. Moderate GCS is 9 to 12, and that's a mental status change of greater than 30 minutes up to 6 hours. And then severe is a GCS less than or equal to 8, and that's a mental status change of greater than 6 hours. And there is definitely some gray area between these severities, and children can most definitely go from a moderate to a severe or a mild to a moderate, which is why neural checks and GCS are important as well. We want to catch that if they're decompensating. So concussion, I'll go into a little bit more of a definition for a concussion. Make sure I have my notes. And so a concussion is manifested by at least one of the following on this list. So any period of loss of consciousness. Like I said before, they don't necessarily lose consciousness, but they can. And it'll be less than 30 minutes. Amnesia, and this is amnesia before or after the event, but less than a 24-hour time period, either before or after or combined. They'll have an alteration in mental state at the time. They can feel dazed, confused. Sometimes they might say they kind of feel fuzzy. They have any other neurological deficits, they'll be transient. So like I said, less than 30 minutes for LOC, and a GCS of 13 to 15 at 30 minutes. Because they can lose consciousness, their GCS would actually be much lower. So after 30 minutes, they should be back at 13 to 15. And then the amnesia within a 24-hour time period. Of note, some brain injuries that are excluded from concussion are any kind of anoxia from stroke, a tumor, encephalitis, and also to note that most often when these kids are scanned, whether it's a CT or an MRI, their imaging is normal. So that you're not going to see anything on the scan, but they will be symptomatic. So it's more so than diagnosing it based on imaging, it's diagnosed based on clinical criteria. So let's see, and also keep in mind that patients may not only have an injury in the area of impact, say they hit their head on the dash of the car, and then their head flies back. So they're going to have an injury from the brain hitting the front of the head and then hitting the back of the head. So it's the coup and the contra coup. So a little background information on traumatic brain injury, and all this data is pulled from the CDC website. It only goes up to about, I think it's 2001 to 2010, so I'm not sure what it is in recent years, but it definitely has been increasing over the years. But the most recent numbers they have are that almost 500,000 kids visit the EDs in the United States, and this is just the United States, each year for some kind of traumatic brain injury, whether or not it's mild, moderate, or severe. That's a lot of kids each year that are going to an emergency department for a brain injury. In 2009, close to 250,000 of those 473,000 were treated for sports or recreation-related injuries that included a diagnosis of TBI or closed head injury. They may have some other kind of injury, but they also had some kind of head injury. So I'm sure everyone's been seeing across the media all the statistics on brain injury related to sports, and oftentimes it's focused on older adults or young adults who are in college or high school baseball, but younger kids as well have brain injuries from sports or recreation. And last year, we ourselves had more than 850 visits to our emergency department for traumatic brain injury of all severities. And I hope my numbers are right, but I found that we have over 4,000 to 5,000 visits each year. Is that right, Stacy?
Yep.
Okay, so that's about 2%, which is a pretty good chunk of the ED visits. So this is a graph that I made for traumatic brain injuries in the U.S. And on the CDC, they group it by age, and it's 0 to 4, 5 to 14, and 15 to 24. So, of course, we fall into the 0 to 4 and the 5 to 14, but we also have a little bit of those 15 to 24-year-olds that hit our doors. But you can see that since 2001 to 2002, the amount of TBI-related visits has increased exponentially. For the 0 to 4-year-old age group, it's up 97% from 2001, and this may be higher now because that's now 6 years ago. For the 5 to 14-year-old, it's up 78%, and the 15 and greater, it's up 70%. So a lot more kids are coming in with head injuries. And this may be because they're actually coming in and they wouldn't before, or there are just more injuries. So as far as causes of traumatic brain injury, and this is still from the CDC, falls represent about 55% of all TBIs for all the age groups combined, followed by blunt trauma, motor vehicle crash, and then assault. Of note, and quite sadly, the leading cause of death for our patients who are 0 to 4 years is actually assault. And the leading cause of death for the rest of the age groups is motor vehicle crashes. And as seen in the graph, 0 to 4-year-old, we have the highest number of visits by the younger age group. Okay, so on to post-concussion syndrome. There are a few studies that focus on post-concussion syndrome, and like most things, even fewer that are pediatric focused. But if you look at the literature, the experts predict or estimate that about 6 to 35% of children with TBI develop post-concussion syndrome. So that's a pretty good, if there's 100 patients, that's 6 of them that will have it. And if you look on the higher side, close to 35, 40. And then there was another study that showed, and these were both pediatric studies, that showed 29.3% presenting to the ED developed PCS. So a pretty good portion of our concussion patients develop this syndrome. So there are a couple definitions that are found in the literature regarding PCS, and the first one is taken from the World Health Organization. It's from their ICD-10, and it's as follows: history of head trauma with loss of consciousness that precedes symptom onset by a maximum of 4 weeks, so it has to happen in 4 weeks, and then it includes 3 or more of the symptom categories below. And you do see patients who have headaches, dizziness, irritability, insomnia, and then the reduced alcohol intolerance, which we probably don't see quite as much, but maybe seen in some of our older patients. And then they have a preoccupation with the above symptoms and a fear of damage with hypochondrial concern, and they adopt this sick role and become afraid that they're never going to get better, that it's never going to stop. And there was a study that was done in 2012 that showed that it's not a pediatric one, it's an adult-focused one, but using these criteria, you're 6 times more likely to accurately diagnose a patient with post-concussion syndrome. So it's a good idea to look at that. There's another definition that I found. It's taken from the DSM-4, and it's as follows: history of trauma that has caused significant cerebral concussion, example, loss of consciousness, post-traumatic amnesia or seizures, neuropsychological evidence of difficulty in attention or memory, and then 3 or more of the symptoms below. And these symptoms result in a significant impairment in daily functioning that reflects a decline from prior to the injury. And then the same study that had stated before that this definition was 6 times more likely, or 6 times more sensitive in identifying patients, said that this one was too conservative, so they preferred this one. And then of note, as I was going through it, I was reminded that there's actually a DSM-5. And so I looked through that, and post-concussion syndrome is actually under mild neurocognitive disorder due to TBI. So the definition is a little bit different than DSM-4, and I did not see it in any of the literature that I looked at, but it is a definition that's out there regarding post-concussion syndrome. So as far as predictors, these are the most common predictors that were found in a pediatric study looking at post-concussion syndrome in mild traumatic brain injury patients. And it was of adolescents, a female adolescent. The patient went to head CT, where they had symptoms that triggered the physician to order a CC on the patient. They received analgesia or analgesics in the emergency department. They had headache on presentation. They were admitted to the hospital. They were in the process or having the intent of suing, which was quite interesting. There was another study that found this in adults as well. And of note, this study commented that they had not seen this before among children. So it kind of plays into mind like what the parents are projecting on their children as well. And then those patients who had missed 2 or more days of school. And the mean for these patients was 7.4 days missed, so about a week. And they did not find a correlation between repeated head injuries and post-concussion syndrome, but there was another study that was not a pediatric study, but they did find a correlation. So that may or may not be. Most common post-concussion syndrome symptoms. The top 3 in this order were headache, dizziness, and fatigue, and then the rest are in no particular order, but were common among the patients who developed it. So the frustration, problems concentrating, memory problems, sleep disturbance. I mean, there's a whole gamut of symptoms that these patients were reporting.
How long are these symptoms lasting?
I'm going to get to that.
Oh, okay. I didn't know if you said it.
And then this was just from one study that I found, but they overlapped a lot with the other studies, the symptoms that they were reporting. The top 3 kind of differed a little bit, but generally fatigue and headache and dizziness and or irritability were the top symptoms that these patients presented with. So treatment and discharge instructions, we want to have headache management, pain management. We want to use analgesics. They recommend initially just to use Tylenol, not to use Motrin because of the risk of bleeding. And then activity rest and brain rest. So they should be resting quietly, napping frequently, making sure they get a full night's sleep, as much sleep as they needed. They should not be forced to do anything. You want to avoid bright light if bothersome. They need to make sure that they're staying very well hydrated and eating a healthy diet. And they need to avoid screen time, which is like text, computer, cell phone, TV, video games, which I know is probably very hard for these parents to prevent their kids from doing this, especially when they're not really allowed to do much else. So if they're going to be having screen time, make sure it's either limited or if they're not, no like action-packed video games, they're watching a movie, more like a cartoon or a chick flick, not, Transformers where they're all over the place and the lights are flashing. So there are things that they can watch that will not cause as much activity in the brain so that the brain can rest and heal. They should not be going to school. They shouldn't be doing any homework, and that means no take-home tests, no studying. They should avoid reading. They should not be exercising, and especially they should be not doing sports if they have a sports-related injury, and should not be driving if they're of age to drive, although they can do walking for short distances, but you want to make sure that if their symptoms increase with any activity, that they have to kind of pull it back a little bit. It's a lot of symptom monitoring. If they're okay at doing whatever and their symptoms don't get worse, it's probably okay. Want to make sure that they get a follow-up appointment with their pediatrician or their primary care provider, who will give them a back to school, back to sports clearance. And it's generally at least 2 weeks that they're going to be out of school in sports. Some of them may need speech-language therapy, so that's something to watch out for our patients age 2 and older. If they're in the hospital and they have symptoms, then they should probably have an evaluation by speech-language therapy, because there may be some kind of cognitive deficit that you don't really notice just talking to them. And then they may need follow-up neurocognitive testing as well. And then there was a study that showed that simply by reviewing the discharge instructions, reviewing the symptoms, reviewing the course of what may happen with post-concussion disorder, decrease the incidence and the severity of symptoms. So you want to empower the families and children to know what's going to happen to them, know how long it probably should last, and what they should be seeing and what they shouldn't be seeing. And it showed that their symptoms were less because of this. And so this is important for nurses. Like the trauma team will go over stuff, but our nurses definitely need to reinforce this and go over, once again, with the patients and the families about concussion and PCS. So as Sarah asked, on to duration. There's a study, and this study had 670 children that were surveyed. And after 1 month of time, only 58%, about half, a little over half, still had symptoms after their concussion. After 3 months, it dropped significantly. It was a little bit higher for those kids that were older than 6 years old. So they had 13.7 compared to 11%. And then after a year, only 2.3, which was 15 out of the 670, had symptoms after a year. So very likely that your symptoms will resolve in 12 months, which is something you can tell the families so that they won't worry as much, because one of the problems with it is like they said, they get to this point where they feel like it's never going to go away. Their symptoms are never going to get better, and it's, I can't imagine not being able to do anything but sleep, and you can't text, you can't watch movies, you can't do this, and anytime you do something more, your symptoms get worse. So in this study, the most common symptoms that increased from before the injury, so these are symptoms that the patients already had that became worse, were fatigue, they were more emotional, more irritable, and they had more headaches or more severe headaches. And there's a high probability that the patients would remain symptomatic if they had a more severe injury, and more likely if they were older than 6 years old. So I have a case study of a patient that we had. So she was an 11-year-old female. She had 3 concussions in 2 months. Now remember, one study said that doesn't really have any correlation, but then another study said it does. So you can see it's kind of hard. There's not much out there, so we kind of have to look and see what there is and then go with it. So her first concussion was in December. So she was hit in the head by a soccer ball. She fell, and then she fell down and hit her head. And then that night she fell out of bed and hit her head. So this is concussion number 1, but I personally see at least 3 injuries to her head in this. So her symptoms included dizziness, she felt kind of off balance. She had some left eye blurriness, and she actually had some inflammation of her left eye. She had some light sensitivity, headache. She was taking NSAIDs, but they only provided moderate relief, so she still had a headache. When they did their assessment, she had some tenderness to her left forehead and her occiput. But of note, she had no numbness, vomiting, tinnitus, disorientation, weakness, or memory loss. So, she goes home, and then in January, she hits her head on a walker at school. Now this kind of sounds like me, I'm very clumsy. Fortunately, I didn't have this many concussions, but hit your head on a walker. So she had, and this was on the left side of the head again, she had immediate dizziness and pain, and this time she had gait changes. So she had some problems with balance, and every time she tried to increase her activity, her symptoms would get worse. She would try to go back to school, and then she ended up starting physical therapy, and her symptoms got worse. So then she had concussion number 3. She hit her head on the faucet in the bathtub. So same side of the head, very unlucky. Left side had pain, and it was immediate pain and dizziness and gait disturbance. Now, in between these other concussions, she had the symptoms, but they kind of resolved, and then they would get a little worse when she would increase her activity, but it wasn't a constant pain. So when she had the next injury, it was immediate. She still had no loss of consciousness or vomiting, but it was kind of confused this time. So she came in, and she had been seen at a concussion clinic and started the physical therapy before this for her symptoms. So this entire time, she was out of sports. She liked to dance and do PE. She had none of that. She missed a few weeks of school because every time she would try to go back, she would get worse. And she was started on PT for her symptoms. And the symptoms that were chronic were balance issues, intermittent dizziness, difficulty with gait. She had the inability to walk up and down stairs. And she would get a headache every time she tried to read. So we'll go back to our predictors for PCS. If you look at it, she falls into most of them. She's 11 years old, so she's an adolescent, female. She had a head CT, but it wasn't until the last admission or last visit to the ED, so that doesn't really count at the beginning. She did receive analgesics. She had a headache each time. She was admitted to the hospital, but that wasn't until the last time. And I do not know if she had the intended student, but I hope not. And she did definitely miss more than 2 weeks or 2 days of school. She missed a couple weeks of school, several weeks of school. So you can see if you look back that she definitely had predictors to develop this post-concussion syndrome. And then in addition to this, she did have the repeated concussions, and whether or not that contributes to post-concussion syndrome is significant for repeated injury. So she would admitted overnight. She did finally have her CT, which was normal, like most concussions. They don't show anything, but still important to get them. She was treated with pain management and then was supposed to follow up at the pain concussion clinic. So nursing care for post-concussion syndrome, I think one of the big things is pain. Like I said before, Tylenol. Most often not Motrin, although I did see that she got Motrin, but it was later on. Zofran for nausea, and fall prevention. Especially for our patients who have problems with dizziness and gait disturbances, they're definitely at a very high risk of falling. So we want to be aware of that and have our fall injury prevention implemented. Low stimulation, so lower the lights, try to limit the TV time, and if they insist upon watching TV, guide them to things that are not quite as stimulating to the brain. You want to make sure you cluster your care, so you don't want to come in like every 20 minutes to do something. You want to, I have to give this med and I have to do my assessment, like do it all at once, so you can cluster their care and allow for a lot of rest. And being in a room with a crying baby next door is probably not the best placement. I know, we all know we work here, you can't control everything, but if it's possible, not have them in a room that's really noisy. make sure that they stay hydrated and they eat a healthy diet. And then, as said before, you can reduce severity just by going over symptoms and course and that kind of stuff. So you want to review the discharge instructions carefully with the parents and the child, depending on how old they are. So lastly, I'm not sure I didn't miss anything. Lastly, there is a study that's going on in the emergency department. I'm not sure how many of you are ED nurses, but it's the S100B study, and Brian Cooper, who's one of the fellows, is involved with this. And basically, what they're studying is S100B is a neuroprotein, and so they're trying to correlate an increased serum level of S100B with patients who have traumatic brain injury or closed head injury. So if they have a TBI or a closed head injury and they're getting a CT scan, they need to have some blood drawn. And this is a verbal consent. It's gone through the IRB. We just need verbal, at least at this point. And in each of the trauma rooms, there are a box. It's like a banker's box, and it has 2 plastic file folders in it with the paperwork. And so it looks like this. And there are 2 sheets in it. There's going to be one folder that says not new and one that says done. So this will be in the new folder. And you're going to take this, and one is the requisition for the lab, and one is the data collection sheet. So then you're going to get 3 labels and label them S100B, and you're going to label the blood that you draw in each of these sheets. So you'll send the blood in the sheet to the lab, and then you'll fill out the other paper and put it back in the box. And it does include some exclusion criteria, which are greater than 18 years old, greater than 12 hours since trauma, brain tumor, penetrating head trauma, which is like a gunshot wound or a stab, and history of melanoma, which I do not know what. But you need a minimum of half a cc of blood, and you're going to get this. When you draw your other labs, you should not be drawing these labs just for this. It needs to correlate with the other labs. And then Michelle and Brian are the primary investigators. So if you have any questions, you can most definitely ask them about it. But it will be interesting to see. So does anyone have any other questions? Yes?
Yeah, on your 0 to 4 years of age.
Yes.
For the traumatic brain injury.
Pardon me?
For the traumatic brain injury. So what are some